So MLD is mitochondrial leukodystrophy. It is a type of leukodystrophy which is inherited in an autosomal recessive manner. It is a lysosomal storage disease where an enzyme called aryl sulfatase A is deficient. In this case, we have accumulation of a substance called sulfatides, which is a type of lipids, in the central and peripheral nerve system, eventually leading to loss of developmental skills, seizures, change in behavior, and eventually death of the patient. There are three types of metachromatic leukodystrophy. The first one is the late infantile type, which is usually present between the ages of half a year to 2 years of age, and this is the most common one. There is a progressive regression of the child or the baby that have this type of condition, with loss of ability to walk and talk, and again eventually seizures, and it does lead to death quite early. The second one is the late type, which are both juvenile type, which is usually between the ages of 3 to 14 years, and the adult type. Those types are more slowly progressive. Brain MRI will show a specific pattern of MLD, which is leukodystrophy, and the diagnosis includes the biochemical testing of the enzyme activity, as well as detection of those sulfatides in the urine of the patient. Therapy options are quite limited. One of them is halogenic stem cell transplantation or bone marrow transplantation. Actually, this is the only clinical available treatment that we can offer now, except for supportive treatment for seizures or for pain. It is described in other selected metabolic conditions, and it is quite validated treatment. In the case of metachromatic leukodystrophy, it is mainly used in the late type, in the late juvenile and the adult type of the condition. It is important to explain what is the pathophysiology of the bone marrow transplant. Basically, we will transplant cells from a donor that have normal enzyme activity, hoping that those cells will eventually pass the blood-brain barrier and proliferate in the brain to a type of supportive cells. They are supportive to the neurons, called microglia, and secrete the wild type enzyme later on to be used by the neurons which are deficient with this enzyme, and hence improving or halting the disease progression. This will eventually take some time, and usually between 6 to 12 months, where the patient will continue or progressively deteriorate at that time. And this is why it is currently an option treatment for the late juvenile and the adult types, which are slower in progression, hoping that the patient will not severely or rapidly progress after the transplant had been done. In the case of the late infantile and young children with MLD, usually they will not benefit from a bone marrow transplant because their disease is so rapid. The case that we described is a case of a child that was diagnosed at the age of 3 years. She presented originally at 3 years of age with abdominal pain, leading to the diagnosis of cholecystitis, and her gallbladder was removed. A pathology report described gallbladder polyposis, and the diagnosis of metachromatic leukodystrophy was one of the diagnoses in the differential diagnosis from the pathology report, and surgery referred her to our clinic. We did the enzyme activity that showed reduced enzyme activity. Urine sulfatide were very high. This had confirmed MLD in this child. We sent molecular testing that showed that she has 2 mutations, and again, the molecular diagnosis was established. Doing a clinical assessment as well as developmental assessment. And we also did some MRI studies, nerve conduction velocity studies, and neuropsychiatric assessment for her. All were normal. At this point, she was around age 4, and we decided that based on the fact that she is asymptomatic, probably she would have been eventually a late onset MLD, and that as an asymptomatic patient, she might gain and benefit from bone marrow transplant. 7 to 8 months ago, she went through a transplant from a non-family donor, which was successful. And enzyme activity was repeated at 1 month after bone marrow transplant and at 6 months after bone marrow transplant, and showed normal enzyme activity in her blood. Repeated nerve conduction velocities and repeated MRI were also normal. Physical exam showed normal, well-developing child that recently went back to school and enjoyed daily activities. And we wanted to present her because this is a rare case where we were able to diagnose a case of MLD before actually we had a neurological presentation of the disease. And we hoped that we will be able to halt the disease presentation by doing bone marrow transplant. Since we know that there is this 6 to 12 months period that disease can progress, we continue to monitor her very carefully now.